So I said, I don't want to be a chairman anywhere. I don't need that aggravation of all that administration. They go, no, 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 this isn't it. You go, well, I don't want to take over someone's existing center because it's, I have to change the culture and that's no fun. They go, no, that's not it. So I go, what is it? It says it's to be a founding director of a neurodegenerative disease center that, just by the way, has a $25 million endowment. So now they got my attention. And I tell you, I came to visit Arizona, and I was stunned on how fabulous the science is in Arizona, both in Phoenix and Tempe. And that really changed my mind. And I decided that I wanted to pursue this job. It's my dream job. It's exactly, if you said to me before I got the phone call, would you define your dream job? That would be how I define my dream job. So now I had just one other issue I had to deal with. I had gotten remarried about a year before. And so I went to my wife. I said, Janet, I think I really want this job. I'm not going without you. And she says to me, darling, when I fell in love with you, I thought I was going to be stuck in Chicago for the rest of my life. Says, I want to go somewhere warm. And last time I looked, Arizona is warm. So I can just tell you that I'm thrilled to be here. I love speaking to patients, and I know patients appreciate when I give these lectures, but I got to tell you something. I learned so much from interacting with the patients, and I always tell my students that you can't really understand Parkinson's disease unless you speak with patients and go shadow physicians. And so, again, I'm very grateful to be here. I'm going to get ready to show my slides. I'm going to talk about cell and gene therapy. Parkinson's disease, I'm not going to talk about Huntington's disease today, although I could. So are we near a cure? So I'm going to give you the answer right now, okay? Then I'll backtrack and show you the data and everything. First of all, with stem cells, it will never be a cure because it's not designed to be a cure. Dopaminergic stem cells are designed to give you more neuronal-like delivery of the transmitter that you've lost in Parkinson's, namely dopamine. And so all the things that levodopa can do, stem cells will be able to do. So you'll have much better motor control. But you won't have these disabling dyskinesias because you'll have more cells that are processed the levodopa. So that's really good. And I'm going to show you a video to illustrate that point in terms of levodopa in just a minute. Gene therapy has a greater chance of, I don't like the word cure. What I like is the word disease modifying. So we can prevent you from getting worse. So, some of the gene therapies I'm going to talk to you about can be disease modifying. And we're still at the beginning of this process, but I have confidence that this will get better as we go along. I got a lot of slides in my slide deck. I actually there's something we just published this week that I think is a game changer for Parkinson's disease. I'm going to try and get through that. It's a little more dense than some of the other stuff that I'm going to talk to you about today, but I think it's important for you to know. Just one word about my center. I'm thrilled to be directing this center. We have 3 missions. One mission is to prevent, cure, I use the word cure, and minimize the disability of individuals with neurodegenerative diseases. We want to minimize the burden of families and their caregivers. I emphasize a couple of things. The rigidity, so we diagnose Parkinson's disease clinically, and you have to have bradykinesia, you have to have slowness of movement, then one of the following. You need cogwheel rigidity, resting tremor, postural instability. Some people use a response to levodopa as an additional feature of diagnosing Parkinson's disease. But this is the main motor features of Parkinson's disease, and it's caused by the loss of these neurons in the brain stem. This is a human, Parkinson's disease, and age-matched control. You see the black stuff there? It's substantia nigra is Latin for a black substance, and these cells die, and that's why you get these symptoms. And even myself and other people, we spend too much time working on this system because it's an easy readout for us. But the real problems, we know, we understand that the real problems are many of the non-dopaminergic features. I remember one of the first times I gave a talk to patients. And I'm talking about bradykinesia, I'm talking about all this other stuff, and they're getting sort of the glassy eye look, I can see from the stage. And then I said, oh, and we're working on something for constipation, and everyone sits up. Now they're interested. And so we have to learn that there are these other issues here that we need to address, and we need to get funding to address, especially, and I'm telling you that I am turning my lab over to be much more studying cognitive dysfunction in animal models of Parkinson's disease and eventually in patients with Parkinson's disease. Two things that get patients into nursing homes: fall and you break your hip, or you get cognitive impairment, and those are the issues we need to address going forward. So how am I going to cure Parkinson's disease, or try to cure Parkinson's disease? I know what you're all thinking. I know what you're thinking. This is going to take a miracle. No, it is Hanukkah. This is from Passover, but there's Moses parting the Red Sea. And the reason I'm confident we can make great progress and have another miracle is because we've already had miracles. So David Marsden said that we have two miracles. I'm going to show you what I think is a third miracle in Parkinson's disease today. But the two miracles you really know. The first one here, this is a woman, who can't get out of the chair. I didn't show for brevity, I'm not showing the whole video. She can't get out of the chair. The doctor asks her to touch fingers to nose kind of thing, and you can see she's very slow. She's hunched over. And then, and as always with Parkinson's disease, or almost always, she's slower on one side than the other because it starts asymmetrically and progresses asymmetrically. And then you give her L-DOPA and she can walk. Miracle. She's also a little dystonic in her hands, but that's a little price to pay for someone turning on to levodopa. First time I ever saw this, it was just amazing. Okay, so just amazing. But this is the problem. Eventually, almost everyone gets these dyskinesias. Sometimes not so troubling as this woman, but we got to do something, and stem cells can do this. Stem cells will reduce the dyskinesia profile because you're going to be able to lower the dose of levodopa, so you don't have these dyskinesias, but still have the anti-Parkinsonian benefit. Now, the other absolute miracle, as many of you know, anyone here have DBS? It's fantastic, and you can pick the right patients. Whoops, but I just want to show you that this miracle here, deep brain stimulation, this is a person off medication. This is a person preoperatively, and it's just awful, just awful. A nurse is going to have to come in and catch him because he would fall. And so the nurse is going to put him back. We put these deep brain electrodes into either the subthalamic nucleus or globus pallidus, two brain regions that we know are overactive in Parkinson's disease. It's a miracle. And you know what you could do? The patients who really turn on to levodopa, but have these disabling dyskinesias, that's the perfect patient for this. If you don't get a big bump from levodopa, at least in the on period, not really a good patient for this. But these are the two. I'm going to show you a third in a little different part of my talk. And why do we have to do this? We have to do this because if you think COVID is a pandemic, Parkinson's disease and Alzheimer's disease are pandemics. And by 2040, there'll be 17.5 million patients with Parkinson's disease. 17. That's going to break the bank. And also with Alzheimer's disease, it's going to be like 25 million. So why are there so many more? So, why are we getting so many more patients with Parkinson's disease? Well, first of all, I think this makes up a small part of this is it's an age-related disorder. The older you get, the greater the chance that you get it. People living a little bit longer now. But there's one other kind of interesting thing that I found. So people don't smoke cigarettes anymore. And smoking cigarettes is protective against Parkinson's. Now, do not go home to your family and say, Dr. Cordova said we can smoke cigarettes because they'll prevent us from getting Parkinson's disease. No, that is not the message. But I just found it to be an interesting part of why there are so many more patients with Parkinson's disease. So we talked a little bit about, so I showed you the nigral cells that are lost, but the real point is it's not really the nigral cells that cause your symptoms. The region here, the region right here, this is a dopamine PET scan. That's all you need to know. And you see, this is the region here in a healthy brain that degenerates principally in Parkinson's disease. It's the other end of the elephant. It's the area called the putamen that loses 80% of its dopamine before you even can get diagnosed, because that's how much dopamine has to be lost. And so that also gives us a problem in that we want to intervene early in the disease. Now, early in the disease for a clinician means, oh, that's when I diagnosed them. But early in the disease for a scientist like myself, that's decades beforehand when the brain starts to degenerate. And that's what we really need to get to. I don't know if anyone's been following one of the great breakthroughs in Parkinson's disease research, this alpha-synuclein seeding assay. So you can take subjects before they even have symptoms, and you can get cerebrospinal fluid and then do a test in a culture dish, not a culture dish, but do a test, and you can say that person's going to get Parkinson's disease. And that person will not get the other atypical Parkinson's diseases like multiple system atrophy or cortical basal degeneration. So this is one of the major pathologies that we're dealing with here. So I was doing a gene therapy trial, did all this preclinical work, everything looked fantastic. And I founded a company called Serogene, and we were delivering a trophic factor by gene therapy, and it failed. I'm thinking, how could it possibly fail after we did all these preclinical studies? And so we're sitting in a room, and to get into the trial, you had to have Parkinson's disease for 5 years, because if you try and take someone early in the disease, earlier than that, you're prone to misdiagnosis, and that really screws up your trial. So, but by the time we have 5 years of diagnosis, there's no dopamine left for the trophic factor to work on. So that's one feature of gene therapy that we have to keep our minds on. I'm going to spend some time a little later in the talk looking at Lewy pathology. The other classic pathology in the brain is this protein that normally occurs, but it gets misfolded in its shape. It's sort of like your garbage disposal, having all this crap thrown down there and it can't work anymore. That's basically what alpha-synuclein does. And we're doing a lot of gene therapy and other approaches to try and remove this gene therapy. But first, I'm going to talk about cell replacement strategies. So it's not really a very new concept. I think this says 1890 over here. And this is, a bunch of these different slides. Anyway, not important. He says, of course, I had no expectations of being able to restore or abolish function in the operation, but the question of vitality of the brain tissue and the course of its degeneration is a subject for very wide interest. And indeed, but it was really the 1970s when a couple of groups demonstrated using fetal cells, fetal rat cells grafted into Parkinsonian rats, that Anders Björklund from the University of Lund and his partner Ulla Lindvall from the University of Lund, as well as John Sladek and Barry Hoffa from University of Rochester, Barry Hoffa from Colorado, Lars also from the Karolinska Institute. They discovered that you can get these cells if you get the right age, early in gestation of a rat, make the lesion in an adult rat, put them into a transplant the cells, and then recovery of function, survival, innervation, all the good things that we needed. So the other thing that's important here is that transplantation PD is a very rational therapy. The motor PD, remember just motor PD, that's what we're talking about, is associated with relatively specific dopamine neuronal degeneration. We all know that. Dopamine neurons provide tonic stimulation. So the dopamine is just being squirted out all the time. It's not burst type of delivery, it's tonic delivery. Dopamine replacement therapies provide dramatic clinical benefit, like levodopa. So if levodopa works, why shouldn't a transplant work? Then finally, it's the potential to restore normal anatomy and physiology of the transplanted regions. So I went to the University of Rochester in 1984 as a postdoctoral fellow. And I walk in, I go, Don, my mentor, I go, Don, I'm here. He was doing a different model, a model of just to demonstrate cells can work, not Parkinson's. I go, I'm here. I'm ready to do the transplants. He goes, no, we're now a Parkinson's lab and you're the monkey guy. And totally changed my life. You know, sometimes you got to be prepared to pivot one way or another. He pivoted for me. And we got to do all these really amazing studies. And also I got to meet patients with Parkinson's disease, which is my passion to try and help. But this was the era of the Bush administrations when you couldn't use field resources, federal resources, to do any transplantation using fetuses, human fetuses. And so we tried all these other things. Adrenal cells. The adrenal cell sits right above the kidney. And if you take out the one part, not the cortex, the adrenal medulla, the inner part of the graft, it makes a little bit of dopamine. In animal models, it really didn't do very much. But I'll show you what the craziness that occurred during this era in just a second. But there are these other dopamine producing cells. None of them work very well. The only ones that work are fetal dopaminergic progenitors, so you take it out of the fetus, or dopaminergic stem cells, and we're going to talk a bit about both of those in just a minute. I'll skip that. So, transplantation field has a wild history, just craziness. People trying to be famous without having scientific data to back up anything, and it's really just it was awful, just awful. And this is this is Ignacio Madrazo from Mexico. And so after all these adrenal cells didn't work in animal models, he comes around with a paper in New England Journal of Medicine saying that he cures Parkinson's disease with adrenal medullary transplants. But it was all fraud. He made it all up. And so this really set back the field a very long way. So the groups in Lund, the group in Rochester that was part of, and Karolinska Institute, and also in England, in Cambridge, did a whole series of rigorous scientific experiments. And we found that grafted cells in animals can survive in large numbers. They can innervate. That's another very important key part of this. You just don't want the cells to be there. They need to spread their branches out and to innervate the brain. They make normal connections the way a normal brain does. And the reconstruction reverses motor disabilities in a variety of rodent and non-human primate models. Everything that we wanted, this is what we were able to demonstrate. So I was part of a team led by Warren Alano at Mount Sinai, who was a neurologist. Chris Getz was at Rush, my hometown. Tom Freeman was the neurosurgeon, and I was the scientist here when I had hair. So you can tell this was quite a long time ago. And so we did all these clinical trials. We did what's called an open label trials first. That means that the patient knew what they got and the evaluator knew what they got. And so it was open label trials are prone to placebo and bias. But then we went into what we call double-blinded trials. And these were the first, and there were two groups. The group led by Kurt Fried and Stan Fahn, and our group here, led by Warren, Chris, myself, and Tom. And so we have all this great data. We have this double-blinded clinical trial where the patient didn't know what they got, and the evaluating scientist, the clinician didn't know what they got. And then both trials failed. And now we're pulling our hair out. So clinical trials are a funny thing in that when you design your trial, you pick what's called a primary endpoint. You say, this is going to be the most important measure. And then you can have 100 secondary endpoints. And if you don't make your primary endpoint and you make all your secondary endpoints, the trial fails. If you make the primary endpoint and you don't make 100 secondary endpoints, your trial is still a success. And so the primary endpoints here were not met, but other secondary endpoints, I'm going to show that to you in just a second. But then something absolutely wild happened, and it really, in terms of my career, was a signature moment. So I come home one day, this is when I'm in Chicago, just started in Chicago, and on my answering machine, it's blinking. I got a message. And Tom Freeman, the neurosurgeon, calls me up, leaves me a message. He goes, Jeff, one of our patients died from a heart attack 18 months after the transplant, totally unrelated. What do I do? I said, let me tell you what you don't do. You don't touch that brain. You just get it from the pathologist, put it in some fixative, and send it to me, because that's what I do. And so we get the brain, I process it, and this is what we saw. And it's absolutely, it's the first demonstration in the history of the world that demonstrated that you can have dopamine cells survive transplantation in a patient with Parkinson's disease. And the graph is here. See all this dark cylinder spot? This is one side of the brain, this is the other side of the brain. And what you see here, these are all cells that we put into this patient. And the key point here is not only do we get these cells to survive, but we get them to innervate. This area around the cylinder is all innervation, and it's all liberating dopamine. This patient did well following transplantation, although it was open label, so prone to placebo. But still, this was a very exciting signature moment for me in my career going forward, that we were able to demonstrate and publish this in the New England Journal of Medicine. That's how important this finding was. But the question always is, well, that's 18 months. I'm planning on living longer than that. How do we know that it's going to still, those graphs are still going to be working down the road? Well, no one's done more postmortem analyses of graphs than I have. And my last one is this case. And this case is 16 years post-transplantation. And there's another, my colleague, Patrick Brunda, has a 24-year. And these cells always survive. They always innervate. And they always do the good things that we hope they do for our transplantation trials. So let's go back to the clinical trial for a second. So this is the not my study, but the Fried and Fahn study. They had a rating scale as their primary endpoint, Unified Parkinson's Disease Rating Scale. Many of you probably have gone through it. And then if you take all your patients, it doesn't work. And I'm going to talk about sham surgery in just a second, because that's sort of a wild concept as well. So, but if you take all patients, they don't do well. But if you take younger patients, they do. So we still couldn't claim victory here because it's not the primary endpoint. The primary endpoint is all patients. But older patients do bad, young patients do good. So that's one thing. The other thing is, this rating scale is your primary endpoint. We still use it. It's still really the most common way to evaluate patients in a clinical trial. But the FDA is changing. FDA doesn't really care anymore how fast you could do this. They want to know, can you eat yourself? Can you dress yourself? Can you use the bathroom yourself? They call these functional endpoints. Can you live independently versus dependently? That's what the FDA is changing to. And the Schwab England scale down here, looking at all patients, had significant benefit, and that's a functional endpoint. So if they would have chose this versus that, the trial would have been a success and the world of transplantation would have been completely different. For our trial, we had 3 groups. Now, down is good, up is bad, okay, on this screen here. So we had a placebo group that received a sham operation. That was unheard of. We put a person into a head frame for neurosurgery. They get an MRI. They go into the operating room. They get anesthesia. They get an incision made. They get a burr hole made in the skull. We don't pass needles down, but still this patient just, they don't know what they got, and we break the blind after the trial is over. But people say, is that ethical? To operate on someone when they have no chance of getting better? Well, but you see here, actually we don't have a placebo. There are other trials in which we have a big placebo effect in Parkinson's disease. 3 places you have big placebo effects: pain, depression, Parkinson's disease. So you got to protect against that. This is not a therapy, this is a clinical trial, this is an experiment. And I tell you, I lost 0 sleep designing this, about doing the sham operation. No one got hurt. And the one thing I did lose sleep about is because we're putting a foreign tissue into the brain of a patient, we had to immunosuppress the patient, stop their immune system. And that has some toxicity to it, and that's what I lost sleep about. But at the end of the day, that's just what you have to do. So we had patients getting better between 6 and 9 months. Then we stopped the cyclosporin, and then they got worse. If we would have continued the cyclosporin, it's likely that this would have been a significant benefit. But also, we did secondary analyses, just like the other trial. And so if you took more mild patients with a UPDRS score of 49 or less, then the transplanted groups did better, significantly better. So and if they were more advanced, then they didn't get better. So we learned from these. We're not doing fetal transplants anymore. No one's doing fetal transplants. There's no need to do it because we have stem cells. But the rules are likely going to apply. We want to choose younger patients and patients with more mild disease, and they're most likely to benefit from these transplants. So, yeah, so this is just basically summarizing what I just said. So not that important. So, but someone else can say, well, it didn't work. Why are you pressing on? Why are you going further with other cell types when it did not work by the scientific rules of engagement? Well, other drugs didn't work when they first tested. I didn't realize this, but the first 7 studies that looked at levodopa for Parkinson's disease all failed. Can you imagine if they would have packed it in after, a couple of these trials? It would have been disastrous because we still don't have any pharmacological treatment as potent as levodopa, as you all know. So I want to talk a little bit about the transplantation of stem cells. What we basically do in our studies, you can take cells from virtually anywhere in the body. You can take skin fibroblasts, you can take fat, and you can make human embryonic stem cells by treating them with what we call the Yamanaka factors down here. So we take ours from blood. So we just take some blood, we give them the Yamanaka factors, we drive them to being embryonic stem cells, and then we bring them back forward and we make them into nigral cells, not dopaminergic cells, but nigral dopaminergic cells. That's key point. Because the cells, through genetic, through the genes, if they're nigral, they know where to innervate. If they're just dopamine cells, they'll just sit there and do nothing. So we did a variety of studies using our stem cells. Down is good, up is bad. We gave a lesion on one side of the brain for the nigrostriatal system, so we have now an asymmetry. And rats will rotate because of this asymmetry. And then we put grafts in to try and normalize the asymmetry between the 2 sides of the brain. And you can see here in a very dose-dependent manner, if you have a maximum feasible dose in pink, then they get better faster and more robustly. The next dose, high dose, the green slower, but the same endpoint, et cetera, et cetera. And this behavioral changes are coupled with the amount of cells that survive when we go back into the brain. So a lot of you probably are interested in stem cells. My studies, so we think we have the best cells. I'm not just saying that because I'm a scientific founder of this company. But if you look at the amount of change here, and look at the other groups that are in clinical trials or about to go into clinical trials, our cells just outperform. That's just a flat out fact. So and then a very interesting thing happened. I'm in a movement disorders meeting, and a patient who had a special kind of Parkinson's disease, Parkinson's disease that had what we call a Parkin mutation. Basically, this is a form of PD that are just like my rats. All they have is a dopamine deficiency. They don't have all the other stuff. And he goes, please give me a transplant. I said, I'm just not ready. It's not time. I need FDA approval. We weren't ready at that time to do it. And then I was thinking that really I should do that. I should do this particular population, in addition to doing patients with idiopathic disease. And I go to the Michael J. Fox Foundation, and I say, would you be interested in funding a small phase 1 safety tolerability trial in patients with the Parkin mutation? They go, that's really interesting. Let me get back to you. Then COVID hits. The world goes away. And 2 years later, I get a phone call from the Fox Foundation. He goes, remember that trial you wanted to run? I go, yeah. He goes, if you get us a grant in 7 days, we'll give you $3 million to get it started. Now, I'm a generous guy. I'm not going to turn away $3 million because I'm a nice guy. If someone wants to give me $3 million, I'll take $3 million. And so that's what we're doing now. But I ran into a problem. And this speaks to one of my joys about being in Arizona. So this all started when I was at Rush. And I had a movement disorder center there, and I had a hospital there, and I had surgeons there. And it was quite easy to do everything. Then I go to ASU, I don't have a hospital, I don't have a medical center, I don't have a surgeon, I don't have anybody. So the first month I came to Arizona, I gave grand rounds everywhere. I went to Barrow, Banner, Mayo, U of A up in Tucson, and blah, blah, blah. And I formed my team. I didn't need to have one university to support me. I could do it here in Phoenix and in Arizona. So the team here is Paul Larson, who's at the University of Arizona. And in fact, he just turned down a job at Barrow, and I asked the CEO of Barrow, Mike Lawton, if he would let Paul operate at the Barrow. And he looks at me like, are you crazy? He just turned me down. I said, Michael, it's better for the patients because we don't have to ship them all over Arizona. These are sick people, as you know. He said, fine. So Paul's going to operate at the Barrow. Surgical site's going to be Barrow. PET scanning will be done at Barrow. And the radioligands that you need for the PET scanning will be done at Banner. Teammates, it's just fantastic. So that's where we're at. I just want to add one other thing. I said there are 3 miracles that I've seen that I think occur in Parkinson's disease. And this is really something quite special. So, has anyone heard about focus ultrasound? Focus ultrasound is basically, it's a lesioning technique. So you put in a person in the focus ultrasound headset in an MRI scan. We put in these micro bubbles at high frequency, and it basically makes a lesion or hole in specifically the area you want it to. It's the same areas that we use for deep brain stimulation, but you don't have to go on this anesthesia. You don't have to get needle passes, electro passes in your brain. And it's not a it's non-incisional. It's not, I'm not going to say it's non-invasive because we're putting a hole in the brain. And so this is an important feature of of focused ultrasound. I think this is going to turn out to be the third miracle of Parkinson's disease. I can tell you, when I went, so this is the other wonderful thing about being a scientist, you get to travel the world on other people's money. And so I go up to Madrid to see this man right here. That's Jose Obesa, one of the world leaders in movement disorders, and a dear friend of mine. And we're doing work in monkey that I'll just talk about very briefly in just a moment. But he says, we can't get on the scanner yet because we have a patient we need to do first. And so I said, okay. And so he wheels in this woman, and she has tremor that is so disabling that they had to do something. So they put her, so they, first of all, they have her draw concentric circles, and she can't even do it. It's a total waste of time. They put her in the machine. They do the focus ultrasound for about 15 minutes, and then she comes out, and they say, draw the concentric circles. And she's like, this. And then he goes, put her back in, 10 more minutes. Make the lesion just a little bit bigger. She comes out. Perfect. And I'm not sure this data still is holding up. And he said to me that if it lasts for 6 months, it should last forever. And I'm not sure that data is, there's not enough data to make a comment about that. The other thing for using focused ultrasound, I think is going to be incredibly powerful, is using low intensity focused ultrasound. That opens the blood-brain barrier, and you can now get therapeutics that normally you can't get into the brain to get into the brain. And just to give you one little example here, you see these bright spots here? This isn't a therapeutic, but it's a compound called gadolinium. And if you give gadolinium to anyone in this room, you would not see anything. But I opened up the blood-brain barrier here and targeted this region, and we're able to get drugs into the brain using this delivery system. It's not sufficient to have the right therapy if you can't deliver it in the proper way. And a lot of these things are just, have the right therapy, but we just don't have the right way to deliver it so you get the target you want engaged. So now I'm going to switch over to a gene therapy approach, and I'm probably going to end there after this next section. So we believe that Parkinson's disease is a prion disorder. And I believe it's a prion disorder because just like prions, which is a different disease, it's normally found in the brain, just like alpha-synuclein is found in the brain. It then misfolds, just like alpha-synuclein misfolds. It spits out a seed, and the next cell that's connected to this cell picks up that seed, and that cell now becomes pathological. That's what a prion does. The main difference I want for any of you who have been reading about prion diseases, some prion diseases can be spread from person to person. That is not what we're talking about with Parkinson's disease. Parkinson's disease cannot be spread person to person. So we talked a little bit about alpha-synuclein and how it spreads. We believe it enters the brain from two routes. One is the gut, and then it goes from the gut into the lower part of the brain, and or the nose. And it goes into the nose and then spreads forward here. So these transplants, though, provided incredibly important information. This is David Marsden, who I was talking to you about. And I'm presenting the data showing the survival of the fetal transplants. And he comes over to me and goes, Dr. Cordova, can I speak with you? I'd like to ask you a question. That's like Babe Ruth coming to me and going, hey, you want to play catch? I mean, the fact that he knew my name was like one of the most exciting things that happened that day. And he goes, do you think Parkinson's disease will cause the graft to degenerate? And I had all this data that would pointed to the fact that it would not. And this is the 18-month case that I showed you previously. I'm not going to go through this data. It's not relevant here. But I said to him, I do not think that Parkinson's disease will cause degeneration in the transplant. He's nodding. He's looking at me. And then he goes, it's impossible. Parkinson's disease affects those cells. Why are your grafted cells so precious that they would be protected while the host cells wouldn't? So I said, what can I tell you? This is the data I have. And then, as I mentioned, no one's done more postmortem cases than I have. But this is a case 10 years following transplant. The reason I didn't see it initially, because it was just too early. And if you have 10 years following transplant, you have, here's the graph, and you can see these bright structures here. That's the transplanted cells, and they have what we call Lewy pathology. Lewy bodies are in these transplants. Amazing. And so Patrick Brundon and I, so when I first had this, I was going to a meeting in Karolinska, and I go to Patrick Brundon, and Patrick Brundon comes to me and goes, "You ever see any Lewy bodies in a transplant?" And I go, "Uh-huh." He goes, "Come here, I want to show you something." And we went into the room where they decide the Nobel Prize in Medicine. That point of fact has nothing to do with the story. I just like to say that I was in the room where they decide the Nobel Prize in Medicine. And Patrick had the same thing. We ended up publishing this together, and it was a huge game changer for the rest of the field. And basically, what people then discover, and this is the work of Virginia Lee, who really pioneered this, that if you put this alpha-synuclein into a mouse that overexpressed alpha-synuclein normally, it would spread throughout the entire brain. And it was an amazing discovery, but it wouldn't have happened if the transplant work didn't show this. I'm gonna skip that. One other aspect of this alpha-synuclein, remember I said you had the seed, and it goes from one cell to another and propagates and spreads and spreads and spreads. That formed the basis of all these clinical trials that were trying to grab that seed using antibodies and prevent it from spreading. If you can prevent it from spreading, then you're starting at an early area of dysfunction, and you never get worse. And this would also affect the non-motor features of Parkinson's disease, not just the motor features. So this approach is extremely powerful. And the one thing I want to tell you about all of these trials, they all failed. However, I don't want to be Debbie Downer here. There is hope in this silver lining here, because there's data that's just been published by Roche. This was a poster. You can see it's a crappy picture. I took it with my cell phone at a poster. And this is actually a trial that I showed you in the previous slide that didn't succeed because it couldn't meet its primary endpoint. And then they followed these patients for another 3 to 5 years. These patients down here never got worse. While the patients treated with placebo continued to get worse. This is the first evidence that we could reduce synuclein and then stabilize disease from getting worse. So that's one thing that's exciting for the future. We got to build on this, and also still need better delivery. But I think that's a very important aspect of the experiment. So I want to talk a little bit about another type of gene therapy. And this is data, all this data I'm going to show you is by my buddy Chris Bankovich. And this is a trial where patients with Parkinson's disease are going to have 4 different doses. This is just the enrollment at this one time. And he's delivering far more of this gene therapy than anyone else in the world. He covers 63% of the putamen, the area of our target, using his delivery approach. So that's really very good. So one thing I want you to see here is, first of all, he's getting it into the brain, and it's working. You can see that this is from cohort 1. This change here is a 25% increase at 6 months. Cohort 2 is larger. Cohort 3 is even larger than that. And you can see the change. So this is at baseline. And you can see the amount of fluorodopa. You see how it's red here? That's increase in dopamine in the brain. That's how it's signaled here. And so this seems to be working. There's safety and tolerability is outstanding here. And you can see the hot spots here. What they do is they put the vector in with gadolinium, what I showed you before, and you can see it during the operation. So you know how much to put it in, and you know how to do the targeting. So that is pretty exciting. And he's in phase 2 clinical trials now. Phase 2 is a blinded efficacy trial. And we wish him great luck because he's terrific. Because it's really quite interesting. They had 2 different cohorts, a mild cohort and a moderate cohort. And what he's been able to demonstrate here is just look at the red line. That's the motor function here. That mild patients really have a slow progression over time, but moderate patients become mild patients. This is a big change. You know, a lot of times we have these very small changes here, and you don't see very much. But this is a big change. This is a clinically relevant to be able to have your UPDRS score in half. And when you're not taking medication, that's a huge effect. So we're pretty excited about this going forward. And then the outcomes in terms of off time shrink, good on time increases over time, and troublesome dyskinesia basically goes away. So this is a very exciting approach going forward. So I'm going to just close and just show you one other study, because so the problem I have with this antibody approach is it's trying to grab that seed in the extracellular space, the space between 2 neurons. And that's hard. I think most of the bad synuclein is inside the cell. So we didn't develop nanobodies or intrabodies or intracellular antibodies. So we take a synuclein lowering compound and we attach it to these nanobodies. And what happens is when you have too much in the cell, the antibody drags it to a part of the cell that will destroy it. And that way you never have a lot of alpha-synuclein here. And so we make a lesion on the brain, these are rodents, on one side, using a alpha-synuclein toxin. And you can see here, this is an animal that received saline, and these are the 2 intrabodies. And you can see that on the side that is responsible for where we made the lesion, it increases. So what you basically do is you take a rodent and you drag it across the tabletop. And a normal rodent will try and right himself by stepping. And so you can see here that when they give saline, that there's not much stepping, but there's a lot of stepping when you give these nanobodies. And also there's another motor test here with this work as well. And then we were able to demonstrate, so this is the synuclein here, and you can see with these nanobodies, it goes away. So we're very excited about this approach. The part of the problem taking this to the clinic is that our intrabody has both mouse components and human components, and the FDA will never allow you to do that. So we had to go back and humanize our antibodies. And so we have a fully human intrabody now, and you can see here, see how much green is here and how it's lowered here and here. This is the mouse one, and this is the fully humanized one. And so we believe that this is now going to be useful for clinical trials. And then it does everything that we needed to do. The details here aren't that important. And we are excited about forming a company around this and using these intrabodies and gene delivery to reduce the toxin that's most important in the brain. I had the honor and great privilege to give the keynote lecture at the Spanish Royal Academy of Medicine. You can imagine what a thrill that would be. And I was giving what's called the Cajal lecture. Ramon y Cajal in 1903 won the Nobel Prize. He's the only Spaniard to ever win a Nobel Prize. And he is regarded as the father of neuroanatomy. And they have a fantastic museum that they allowed me to go see. And in his writings, Cajal said, you don't see regeneration of the brain. And so now I'm trying to give this Cajal lecture, and it's not just neuroscientists, it's chemists, it's physicists, so I wanted to make it something that they could relate to, that would also honor Cajal. So what I did was I have Cahal's autobiography on my bookshelf, and I'm starting to go through it looking for a nice quote to use. And then I realized this is the stupidest way to try and get a quote ever. So I just went to my computer, I Googled quotes by Cahal, and 20 quotes came up. And this is the one that really touched my heart. I know if Cahal would see the cell replacement therapy and see the regeneration that we can do with gene therapies, I know he would love it, because this is what he said. Nothing inspires more reverence and awe in me than an old man who knows how to change his mind. That shows you what a great scientist he was. He wasn't inflexible in his thoughts, and he had the data lead him to the next step at all times. So I think he would have been thrilled to this. I can tell you, just to summarize, first of all, this is my group. I want to point out this gentleman right here. This is Paul Coleman. He's a giant in the area of Alzheimer's disease and aging. He's 95 years old. He's my postdoc now, because when I came to Arizona State, he was working in my center. And he goes to me, you know, and he was like my advisor when I was at Rochester as a postdoc. So that's how far we knew each other. And so I just love the fact he comes to work. He wrote 3 papers this year. He put out 2 grants this year. And he's just an absolute giant. And these are my kids that do really all the work here. And just to summarize, I have I believe, bright future for stem cell transplantation. The science has been set in fetal transplants, and we know what we can do better. And I think I have tremendous confidence that we will do better, and patients will have great benefit from stem cell transplants. When I showed you that slide where I compared other groups, Lorenz Studer at Blue Rock and Jun Takahashi in Japan already have clinical trials ongoing. Malin Palmer does his Lund as well. So keep an eye out. Right now they're into these phase 1 trials, and it's nice to get in early, but it's not going to be an efficacy trial. So just keep an eye out for these clinical trials. They're all really good scientists and are rigorous and mature about the way they go about things. With gene therapy, there are a lot of different approaches here. I think gene therapy to reduce toxic proteins like alpha-synuclein can have a major impact on the major symptoms that we need to address. And right now, we don't have those therapies for those major symptoms. That's where I'm going to be dedicating my lab to over the next 5 to 10 years. We're going to change from just being a motor Parkinson's lab, but a cognitive Parkinson's lab. And I think that that's incredibly important.